Such a great presentation, Mike, and these have all been absolutely terrific presentations. And we have a couple of minutes for questions. I know at the end of the day, things can flag and you get receptions on your mind. But may I then start with a question, which is great for me. This is perfect. Oh, we have one. Oh, I'm sorry, I didn't see.
Just a short question to Mr. Schrader. What's unique about your PACE? Because I find the integration with UCI clinics sort of interesting but different from other PACEs that I'm familiar with. How do you keep the integration between PACE, which you run, and the medical service that is run by UCI?
So the PACE model is all-inclusive, so we're responsible for all of the services for those members. And what we're doing is just for the clinic that's in our PACE center, that's being staffed with physicians from UCI's gerontology program.
But you don't have any control over their practice.
We absolutely do, the work that they do in our PACE center.
But how can you do it given the corporate practice of medicine in California? As a health plan, how can you oversee the clinic which is run by UCI? That's
So two different things. One is PACE. We operate the clinic within our PACE center, and we have UCI physicians working there under our supervision, under our program guidelines. Separate is, okay, our Medi-Cal and our Medicare programs for individuals that are not in PACE. And for those, we contract with providers out in the community, including UCI and their hospitals and their primary care clinics and all of the other services that they offer.
Are there other questions? Yes, Wendell.
This is for Dr. Thompson. I appreciated your presentation. My two questions are, given how hard red Arkansas went, do the Republicans in your state recognize the benefits of the Affordable Care Act and what you were able to achieve there? And then my second question is, given some of your neighboring states and the one slide you put up there, why isn't your model adopted in some of the other red states?
So part of good policy is trying to play three-level chess at the same time. And one of the things that we knew we would do, but we didn't advertise that would happen, was that when we expanded using the premium assistance model, we would eliminate a lot of patchwork programs that were in Medicaid that we were paying a much higher match rate for. So for example, we paid for 60% of the pregnancies in the state on the traditional Medicaid program, and 30 days after delivery, they were terminated. Well, when you have them in premium assistance, it's a 90% match rate, and they don't get terminated, so the next time they're pregnant, they're still over there. So we actually built in, and when this governor came in, he asked for a task force, because I think he believed that it was going to be unsustainable. But what the out-of-state contractor found was that the premium assistance model, because it allowed Medicaid to terminate these little patchwork programs, pregnancy, TB, HIV, all these patchwork programs, that the premium assistance model saved the state $700 million a year in state match. So they almost became obligated to undo it. It was going to require $700 million in new state revenues. So it was almost like a little sneaky approach there that we did. The other states, Louisiana came on last year. I mean, they had an administration change, and they came on and have expanded now. The Missouri Healthcare Foundation was within a vote of at least having one or two votes in their General Assembly of at least having one end of their capital be supportive. I don't see how these states are going to sustain their healthcare infrastructure, particularly in the rural areas, if they don't figure out a way to identify it. It does take, it's hard work. I mean, putting premium assistance, The insurance commissioner doesn't speak Medicaid, and Medicaid doesn't speak insurance. Those are two totally different worlds. One is a guaranteed benefit on Medicaid side. One is an actuarial risk pool. You're trying to keep the bad risk out. And so it's hard work, but I think we have a couple of states that have approached us for assistance. I'm not going to name them, but I think over time you're going to see conversion one way or another on the southern states.
And may I ask just a follow-up question? In this notion of moving to work requirements, which number one, I think California has to really consider that potentially approval of the next waiver is going to invoke some of that. But the question I would ask is, how do we know if that is effective? I mean, what are the measures? I always wonder, what are the measures we'd use, the right measures, to determine that a policy that says that, quote, able-bodied people must work in order to receive benefits, and then all of the other potential lifetime limits, those kinds of things, that actually works, as opposed to being just a budgetary and an agenda, a policy agenda.
So we have a group of informal group of 4 states that have work requirement proposals either already approved, Kentucky, or likely to be approved. And we're trying to come up with a framework of what the potential outcomes are, good or bad, that should have an evaluation wrapped around it. The danger is that you'll have an evaluation of who successfully met the work requirements and stayed in Medicaid, but Medicaid evaluations rarely focus on people who left the Medicaid program and are no longer beneficiaries. So I think if we can come up with a framework and the right metrics, there is the possibility for a multi-state evaluation. I seriously doubt it will be funded by the state Medicaid programs. It's going to have to be funded by an outside source that doesn't have the political interest to show success in upward social mobility because of work requirements.
Other questions? Yes.
Thank you very much. This is a great presentation. I'm wondering, as far as workforce, and in California, we have such incredible shortages in workforce, and in particular, not just for physicians, but getting patients to and from areas where they need. For example, the PACE program, getting an elderly person from their home to clinic is sometimes a bigger barrier to help them access care. And we're very ethnically diverse in California. So I'm just wondering if we could be innovative about asking people to have a job versus saying, maybe you could spend 10 hours a week working as a community health service to sort of earn credits toward your work requirement. And certainly, if you've had a teenager go through our high school system, I think some of our seniors could skip senior year altogether and do a work-study program and really learn a lot about health literacy and delivery of health care, and have that be credit toward college or healthcare systems. I just feel like we really, it's hard to demand people to have a job, then have to pay for childcare and other things when just to earn health insurance, but rather maybe we could promote their involvement in healthcare delivery as an earning some sort of point, particularly our community healthcare workers, translators, facilitators.
Anybody want to comment on that? If not, I actually, may I comment first, just because?
No, I just wanted to say,
Just because I'm doing a
Great.
peremptory thing here. I just want to note, California we have a health scholars program run by Cope Health Solutions that does that kind of workforce training. And we've graduated approximately 35,000 young people who've been through essentially acting as clinical care extenders within the hospital system. And it does strike me, that this is just a really interesting idea to really start marrying a couple of problems that we have. All right, without interruption.
I was just going to say, I think you're on target. You will quickly find the divide between the social discord, which would give people credit for making a community contribution, and the political interest of just reducing the Medicaid rolls.
All right, Lance, sorry.
No, I couldn't have said it better.
You can, are you sure you don't want to try to say it better?
No,
Okay.
come on.
All right. Yes, one more question, and then it's time to roll on.
Thank you. You gave me a chance to even share this because I'm a living proof utilizing the Covered California. And I've told Dr. Lang, I think a year ago about that on my own personal case. And before that, I congratulate Dr. Schrader for having a very well-defined programs here in Orange County. Because in Los Angeles, we don't have that. I'm an RN case manager by profession, and I'm also a graduate here in UCI for healthcare MBA. So I know how things are flowing in the whole market because I've worked at Fountain Valley from here. So I'm
going to ask, do you have a question?
and I would like to
We're
share,
running
and
out
I
of time,
think,
and I think-
yeah, I'll make it short. But
Okay.
I'm really commending the program, and it's good that you succeeded on that CMS having you continued, and please continue that. And the other thing with Dr. Lang, because if I didn't have the Covered California, although I paid a very high amount, because I took the Platinum $1,000 a month for a year and a half. Before the ACA, if it was not there, I probably could have not gotten insurance because I have two major complications with too many complexities of morbidities, and I succeeded managing my care. Just to make that story short, this is the last thing.
Wait, let me stop. This is more of a comment that I'm sure they're happy to entertain afterwards.
Yeah, but the
there
benefit-
is not a question. We asked
Yes,
for a question.
but the benefit, I just want to reiterate that the Covered California really had made a big difference.
Yes.
And the second thing, this is the last thing. My sister had all this anasarca, nephrotic syndrome, end-stage renal dialysis. I just want to share with you that LA Care from the Los Angeles area really made a big effort, and they're very prompt on doing participative care management, okay?
Thank you. Thank you. That's great. And it's a lot, and I appreciate your giving a shout out to Covered California. They're doing a wonderful job. Thank you guys very much.